Alexithymia is a neuropsychological condition where people have difficulty identifying, dealing, experiencing, and feeling their emotions. Alexithymia is a great example of the misunderstanding that comes with brain injury. In this talk, Dr. Dawn Neumann does an excellent job presenting about what she knows and has come to understand about alexithymia, what her research has revealed, and what her latest research has shown towards treating and dealing with this disorder. And I appreciate her presentation and the discussion that comes up. The brain injury survivors that are dealing with these problems have really good questions that overall leads to kind of like a unanimous front in terms of what the people who are dealing with this have run into in terms of support and lack of help and lack of understanding with this very specific condition. Um, Please check out the Building Brain Awareness information below because there's a lot of other talks and upcoming talks that you can register for. Thank you.
Dawn, my name is Randy. Can I ask you a question?
Sure. Hi, Randy. Nice to meet you. Thanks for joining today.
By chance, are you familiar with Dr. Gabor Mate?
How do you spell the last name?
Mate with an umlaut, I think, on the end.
I don't think so.
He wrote a book recently. He's written a few books, but called The Myth of Normal.
Mate, so M-A-T-E.
Yeah.
The Myth of Normal.
First name is Gabor. He's a doctor out of Vancouver, BC. I mean, he's retired, but I just finished.
He is not focusing on brain injury. His
Oh,
focus.
he's a PTSD. He's like a. I look at him as in the PTSD and the body keeps a score trauma literature.
Oh, is he?
Yeah, I know for Randy.
He's not the author of that particular book.
No, but he's in that same vein of thought and sort of promoting that thinking.
Yeah, I would agree with that, Dan.
Yeah. I've just been observing their stuff as I feel like the brain injury stuff is different, and I don't feel like what they talk about. There may be overlap, but there's enough where I'm like, I don't feel like what they're talking about fits my experience. So, but anyway, yeah. So that's who that guy is. Sorry, Randy. What was your question?
I was just wondering if she was familiar with him or his work at all.
No, but I can look into it. I do think that we can learn stuff sometimes from looking outside of the population that we traditionally work with. I often look to that other literature to sort of inspire me and help me sort of understand. So,
and Dawn, I would add to that, he's very inspiring, not expiring, and he would be a really good one to look at. And I hear and honor the fact that you say there's good things to find because there's overlap, but there's also bias that occurs because brain injuries do resemble some of it. And then that ends up being another obstacle for the brain injured, which is not compassionate. But every fiber of what Gabor teaches is about compassion.
Oh, nice.
Yeah, he refers to it as compassionate inquiry. And what I have found in the course of it's a 500-page book, and going through it, I mean, Dan brings up a really good point because he doesn't mention brain injuries at all. But throughout the book, I kept on thinking to myself, great, how do you deal with this in the context of having a brain injury?
Definitely adds another layer of complexity.
That's an understatement.
Yeah, I'm sure.
Yeah, right. So
I'm sure.
I was just wondering if you were familiar with him at all. That's all.
And thanks for making the recommendation.
Yeah, and it may be a good time to turn it back to Dan to start.
Yeah. Sorry, I didn't want to cut off your question, Randy, but I think we should start now. And I just want to introduce our speaker. Our speaker today is Dr. Neumann. She's an associate professor at Indiana University School of Medicine, and I invited Dr. Neumann to talk about alexithymia. I had been looking in this literature for a while, and I guess the simplest way to think about it, we've had people talking about when you have a brain injury and you can't move your body, when you have a brain injury and you can't think, or you can't use basic parts of yourself. So this is the emotional version of that. And I'll turn it over to Dr. Neumann because she can introduce herself better, and also let's just begin the talk. So with that, I guess feel free to ask questions, guys, but if you want, you can save them till the end, or you can plug them into the chat. Okay.
Sounds good. Thank you, Dr. Avasar. And thank you everybody for joining today. I'm really thrilled to be here and be able to kind of share with you some of the research that I've been doing and some of the information that I've learned over the last several years. Like Dr. Avasar said, I'm at Indiana University and I've been here since 2010. Just to give you a little bit of background about myself, I have a PhD in rehabilitation science from SUNY Buffalo and a master's in cognitive psychology from Rutgers. And way back when, so I'm originally from the East Coast, lived in New Jersey. And when I was there, I used to, in between undergrad and grad school, I worked at various rehabilitation facilities in New Jersey as a cognitive therapist. Which is really interesting because I don't even think that they have a cognitive therapist anymore, because speech language pathologists and neuropsychologists kind of take on that. And I just remember, so I would deal a lot with people focusing on attention and learning and memory and executive functioning. And then, and I loved doing that. And then I had a job where I would go into people's homes. And it was very interesting because it became quickly evident to me that more of the barriers that people with brain injury and their families face is more of kind of the emotional and behavioral barriers. And I just remember thinking I am way out of my depth and way out of my element. And at that time, decided to go back to school. And in my doctoral program, my dissertation advisor, who was from Canada, from Niagara Falls, his name is Dr. Barry Willer, and he's very well known in the world in Ontario and worldwide. He had convinced me to do research in brain injury in terms of how people with brain injury recognize other people's emotions and how this impacts their behavior. And I remember being very nervous to kind of enter these waters because just thinking that, this whole element of people's emotions and behavior is just so complex that I just wasn't sure if it was something that I'd be able to handle. But it turns out that I really love this area, and it's such an understudied area and a much needed area because there's very little evidence. So anyway, getting into it, as you guys know, I'm preaching to the choir that after brain injury, it's really the changes in emotions, being able to manage emotions and how this impacts behavior that are really kind of those things that are most kind of distressing, not only for the person with traumatic brain injury, but also their family and friends. And this is, something that really can be a barrier, I think, when people are trying to get back to their lives and going back home and interacting with their families, their friends, they're going back to work and just engaging in the community and participating. And when it comes to treatments, I think that we have a long way to go. I think that we've made some progress and there are some interventions that have been found to be somewhat successful, but not one treatment fits all. And I think in this area, when it comes to like treating problems with emotions after brain injury, I think there's so many therapists and stuff that tend to utilize cognitive behavioral therapy. So kind of taking how is it that you think about a situation and reframing that to help kind of alter the emotional response. And that's great. But I think that that's an interesting approach and potentially one that might not necessarily be effective if somebody does not, in fact, at first recognize their emotions to begin with. So if you're going to a therapist or you're trying to figure out and control those emotions, how can you communicate and work with a therapist if they're asking you how you feel about something or trying to get at the heart of something and you don't know how to put that in, you don't even know that you're feeling an emotion or you can't put that into words. So I think an area that has come to my to the forefront of my brain is this issue of alexithymia. And it has become my mission in life to increase awareness around the world about alexithymia. I think it's way underrepresented. And it's really interesting because I have people all over the world that contact me about this and not know how to get help for this. And so, so if you've never heard the word before, it literally translates into no words for emotions. And it is characterized by somebody with alexithymia could have difficulty, trouble detecting emotions. So that meaning that, they might have an emotional response to something, but they might not realize when they're having an emotional response. So they don't even realize it's there, but it's there. The second one, this poor interoceptive awareness being, which I actually just realized I think there's a misspelling. But anyway, not being in tune with those cues. So when we have an emotional response, one of the ways that we know we're having an emotional response is through those our body cues. So signals from our body. So kind of our body tension, an increase in our heart rate, an elevation in our body temperature, things of that nature. Those things from our body are cues telling us that we're having an emotional response. But somebody with alexithymia might lack awareness to that, or they might be aware of it, but not connect it with an emotional response, and more likely think that it's a feeling of pain or discomfort rather than attributing it to an emotion. And then others with alexithymia may know they have this emotional response, they pay attention, they know that there's an interoceptive response, but they might have more difficulty just saying, like being able to put a specific label on what it is that they're feeling. So, and being able to describe those emotions. So it's not uncommon for, somebody with alexithymia to be like, to describe their feelings in more vague ways. So, I'm okay or I'm fine, but less likely and more likely to, when asked how they feel, they're going to talk about, well, they're, if they're saying, well, how do you feel about this? They might be more inclined to say, well, I feel this is stupid, or I feel this is dumb, or I feel like nobody cares. Those are not feelings. Those are thoughts that are very emotionally driven thoughts, but they're not feelings. So being able to kind of differentiate those thoughts from feelings, and then, they might be more inclined to say a physical sensation. So I'm feeling tired. Yeah. So,
Can I ask a question
yeah, sure.
about the not realizing it? So I think I was in that camp for a long, long time, like over a decade, and it's hard to tell someone when, if they're saying you're not realizing it, but for me it doesn't exist.
Mhm.
Doesn't how do you, or do you have any thoughts on that, or how do you deal with that with people, or how do you help people kind of work with that? Because the not realizing it, put it this way, I think of the brain injury problems as you have like a list of many, many problems, and they kind of compound and they take center stage. And then if there is emotional stuff, you don't realize it, and it may or may not be there, but it's not on your mind. It's not, you know what I mean?
Right. Yeah. Absolutely. And I think it's a great question. And I was going to so I have an example actually of that. And I don't know if this helps, but this
Great,
is
great,
kind
yeah.
of, this is my take. This is sort of my take on it. And I think it's pretty common, right? So this is that, when you don't realize it's there, right? And a lot of people, will describe that as having the blunted affect, right? And people will say, I'm disconnected. I don't feel any emotions. I go to these events and I don't feel, a funeral or whatever, and I'm not feeling sad. And I know I should be, right? So, yes. And to share a story about this, one of the things that got me into this was, some of you guys on this call maybe know who Dr. Lance Trexler is. He is a world-renowned neuropsychologist. He used to work at the Rehabilitation Hospital of Indiana. He's retired. He called me one day and he had a patient who had a stroke in his office. And the patient and the wife were in his office. And he had said, Dr. Trexler said to me, can you help somebody with a brain injury learn to feel emotions again? And I said, well, what makes you think they don't feel emotions anymore? And he said, well, he says he doesn't. And his wife says, yeah, he definitely is not expressing any emotions. And I was like, okay, and at this time I had learned about this thing called alexithymia, and I started to realize that there is this possibility that there's this disconnect between what's going on internally in the body and that information getting to the part of the brain that helps us be aware of what's going on inside of the brain and what's going on inside of the body. So we have, these signals from our body are getting processed in a part of our brain in the somatosensory cortex. And if that information needs to go through that processing and then needs to be sent to the prefrontal cortex, and if there's a disruption in that process, then this is a possibility that things can be going on internally without your awareness. And so I said, well, I said, I'm just wondering if there might be something going on and it's just not reaching his threshold of detecting it. And it's not able to come out and be expressed externally. So we did this little interesting thing where we had him and his wife bring in like pictures, like emotional pictures of like the day his kids were born and a piece of cloth with his wife's perfume on it. And we wound up hooking him up so that we were able to measure his arousal response. So kind of that response in your body, kind of showing kind of that arousal in relation to an emotional response. And I interviewed him. And as I was interviewing him, and every time I would show him one of these emotional stimuli, his response, his galvanic skin response, went way up. And this is this indicator that internally he's having an emotional response to this, but on his face, you would never know. And so it became this recognition and this awareness that like there is something going on there, despite him not even knowing it. And so, go ahead.
Do you call that disassociation?
I don't know if I would call that disassociation because, and I'm not a psychologist, so I want to put that out there. I am not a clinician. I am not a psychologist. So I don't know what that word means to psychologists exactly. I would say that, so to me, a disassociation almost sounds like there might be kind of, it's more of a psychological thing that's preventing that. Whereas in my mind, when I think about a brain injury and this being, is there a neurological disruption that's minimizing these signals to get from one, and so we know that plasticity help, does work, right? So I'm thinking if we work on training the body to lower that threshold to detect the signals, that this will kind of overcome some of these issues. So I don't necessarily know that I would say in this situation that it would be dissociation or not.
How can you elaborate on what you mean by training the body?
John, before you elaborate, I'm looking for the moment to just ask if anyone in the audience is having trouble with the volume. We have one participant who's having trouble hearing it loud enough, and I've been trying to troubleshoot. Is anyone else having trouble?
No.
I'm not.
Yeah, my volume's fine.
No, I'm fine.
Okay, all right.
So it's
Thank
probably
you.
her
I'll
settings.
go back to troubleshooting. And yeah.
Yeah. So
Can you elaborate on what you meant by training the body?
yeah, and I'm going to get to it a little bit later, although I
Okay.
don't know. And well, I don't know that I actually get too much into it. So one part of our intervention that we do is, well, actually, you know what? We will hold on that. Because I'm gonna
Okay.
tell you more about the intervention, and I'll get to that. If I don't delve into it as deep as you want me to, then let me know.
Okay.
Yeah. So, and then the other issue is difficulty differentiating emotions. So I don't know if anybody here on this call sort of experiences this, but like you might kind of feel flooded or overwhelmed with emotions. So a lot of times if you have an emotional situation, and we never feel just one emotion, there's a lot of emotions going on. And so really, sometimes when people have alexithymia, they might not necessarily know the difference between, do I feel sad? Do I feel angry? Do I feel scared? It just becomes this ball of negative distress and unpleasantness. And so being able to work through those emotions is another piece of it, and being able to label them. One of the things, so I have this, can you guys see that, the yellow thing that says 30 to 61%?
Yeah.
Okay, good. I have something that's covering it. And anyway, so yeah, so the research shows that anywhere between 30 and 61% of people with traumatic brain injury have alexithymia. That's quite high. In people without TBI, it's somewhere between 10 and 15%. So this is a huge issue, right? And I think so. In addition, this is an area that's, like I said, completely under-recognized and understudied. So there was a couple ways that I got into studying this. One, I said Dr. Trexler had called me about this, but I could say why Dr. Trexler bothered even calling me to begin with. So for my dissertation, I did work, like I said, on teaching. I created an intervention to develop to help people with brain injury better recognize other people's emotions. And this article here that was published on Lash and Associates Publishing, this was back in 2010. I don't even think this is on their website anymore. So when I was doing that work, we had created this intervention, and part of the intervention was, okay, based on this idea that in order to recognize other people's emotions, you have to first be able to recognize your own emotions. And so I wrote this article about emotional miscommunication, how it needs to have both parts. You need to be, when you're in a relationship, you need to be able to communicate how you feel, but you also need to be able to read how your partner feels as well. And it was really interesting because my focus was more on the recognizing of other people's emotions. But after I wrote this article, quite a few people had posted comments on the article. And these comments had a lot to do with more about their ability to process their own emotions rather than other people's emotions. So this is one comment. I have no sense of connection to anyone on the planet, despite being married. Having 4 children, 3 are grown up, grandchildren, it is a strange thing to live without any sense of connection to people, moving through each day, trying to understand, wearing a mask sometimes. Most of the time, I'm neutral with no feelings at all. I don't know why, as I have a good life. However, anger comes easily. From that day after the car accident, I've changed. I was no longer connected to my former self. I'm 47 years old, and none of that has changed. The only emotions I feel are anger, non-anger, irritation, and sadness. I can't express anything else. I've gotten divorced, and it's as though I just had roommates for 20 years. No emotional connection to any of them. He is also, this from a care partner, he also has other symptoms of TBI in regard to being somewhat emotionally disconnected, and has told me he does have problems processing emotions, and it's very difficult to sit down with him and discuss his feelings. He can become easily frustrated and angry, and he gets depressed with suicidal ideations. I'm trying to create a loving, supportive, and encouraging environment. I try not to get my feelings hurt when he seems cold and distant, because I do know that he loves me, and it's the injury that causes that disconnect, and I just want to learn how to help him. And so these are really powerful examples, I think, and it made me start to think that maybe more people with brain injury don't recognize their own emotions. And that's the foundation of all of this, right? If you can't recognize your own emotions, you can't recognize other people's emotions. But then I started to even realize that there's a bigger picture to this. It's not being able to recognize your own emotions isn't just about being able to recognize other people's emotions, but it's even bigger. But before I get into that, I just wanted to kind of share with you some more clinical presentations of alexithymia. And everybody looks differently, I think, after a brain injury who has alexithymia, because you may have one aspect of alexithymia or another aspect of alexithymia, or some combination may resonate with you. This first one of these, I don't feel any emotions. That's the example I shared before of that guy with the stroke who's like, I don't feel anything. That's one example, that blunted affect. But then you have this other, I always share this example, and this was somebody in a support group of ours. He was in the support group, and he was clearly getting very angry about something, and he jumps up out of his seat, and he's clenching his fists, and his veins are popping, and he's screaming. And somebody said, hey, it's okay, calm down. Why are you getting so angry? And he screams, I'm not angry. What makes you think I'm angry? So this is a guy that clearly is this expression of emotion, but he has zero idea that he's expressing this, and how it's coming out, and how it's kind of disproportionate to the situation. He's scaring people. So anger is pretty common in people with alexithymia, as you saw before. And then you have these other people that sort of just get by, I think, kind of this middle of the road, that they sort of sense things are going on. They might describe they feel confused. They don't know how they feel. They might talk in vague words like I'm okay, or I feel bad, or stressed, or overwhelmed, but can't get any more specific than that. And then you have these other people who are extremely aware that they have these emotional responses. They are flooded, and all they acknowledge is feeling anger. So these are fairly common presentations of alexithymia, and it may look different for everyone. I think, so the interesting thing, so not only does it have these behavioral things where the way you're expressing emotions and your recognition of it, but it also has been associated, we know from the literature that alexithymia has been associated with poor management of emotions, aggression, depression, anxiety, lower positive mood, more negative mood, worse coping skills, poor recognition of other emotions, lower empathy, poor relationship quality. And I put I should put an asterisk on that, because that's people with brain injury of alexithymia don't necessarily acknowledge their relationship has poor quality. It's the partner who says our relationship doesn't have a great quality. And then overall generally report a lower quality of life, probably because of all these. Just because you don't recognize emotions doesn't mean it's not causing a general distress feeling, and it's harder to find this connection. And so you feel disconnected and lonely, right? And so you're not going to have this quality of life. And so, but why do we see these associations? So I think that, there's a couple of reasons, but, I think that their ability to, you can't manage something that you have zero awareness of. So you need to have some awareness if you are going to be in the driver's seat and decide what you're going to do. So the ability to process emotions starts with recognition of emotions. It starts with labeling emotions. And then until you have that information, it's very difficult to work through what those distresses are. And more recently, and this, we haven't published this, we just started looking at some data. We found that if you have alexithymia 1 year after brain injury, when you look at 2 years after brain injury, your alexithymia from year 1 predicts problems with emotion dysregulation, but also lower resilience and issues with post-traumatic stress. So you just don't have the skill set to navigate and work through and overcome these emotions, which is causing that emotional distress. We also know from neuroscience that if you get somebody in an fMRI machine and you show them pictures of emotional stimuli, and they either have to sit there and passively look at the emotional stimuli, or you look at the emotional stimuli and you label them, you get two different things. If you look at just the emotional stimuli passively, you wind up getting these responses in the limbic system. And that's that part of that brain, right? That's that emotional reaction without cognitive thought. And that's what's going to lead to these behaviors without control. But then you have somebody label the emotions the emotional stimuli that they see. And what happens is you see all this activation in the prefrontal cortex, and you see less responsiveness in the limbic system. So just by labeling something of your emotions, it helps to put the brakes on what's happening, that increased activity in the limbic system. It puts the brakes on that. It's engaging cognitive thought. And so anyway, I think those are some theories as to why we see these associations. So what we wound up doing is we wound up creating this intervention, and we did a pilot test. And this is very, with very few subjects. At the time, we recruited, I think, 17 people with traumatic brain injury. We had, I think, 13 people complete the study. And it was just a design where we looked at people at baseline. We then did the treatment with them, and then we evaluated them immediately after the intervention and in a 2-month follow-up. And so in this small study, just to get this sense of, does this intervention work? How do people respond and react to it? So we wound up, the measures that we were interested in was looking at alexithymia, emotional labeling. We looked at emotion regulation, positive and negative affect, trait anxiety, depression, and anger. And what I will share with you is the intervention, then I'll share the outcomes with you. So the treatment itself that we put together, it's an 8-session intervention. And it is designed so that one of our research assistants who is trained delivers this to one of our research participants. And all of the content of the intervention is on, I say web-based training, it's presented on the computer. So it's really different than what most people think of as psychotherapy. It's very structured, but yet at the same time allows you to personalize it for the person that you're working with. And so the first 4 lessons of the intervention are very psychoeducational based. So trying to get people to understand, why do you want to get reconnected with your emotions? What are the consequences if you're not able to connect with your emotions? And then giving them an emotional vocabulary. So not introducing them to any new words they've never heard before, but getting them to refamiliarize themselves with emotional words and getting them at the forefront of their brain and at their I guess at the tip of their tongue, so that they're able to use these more regularly into whenever they're thinking about what they're doing and how it makes them feel, and being able to communicate this. We spend a lot of time, so going back, I think this was Randy's question, so that helping people to sort of lower that threshold. So one of the things that we do when people don't feel these emotional responses, what we try to do is I guess you would call it a little bit of mindfulness to some degree. I'm not sure if that's 100% the right word, but we have people do body scans. So we'll have them kind of go through and work through from we start with their feet all the way up to their head, and we have them pay close attention to the sensations that they're feeling in every part of their body, and the tension. What are those physical symptoms? What is it hot? Is it cold? Is it tense? Like going through all of their parts of their body so that they can sort of reconnect to paying attention to signals from their body and knowing what that feels like. And then we spend a lot of time talking about what is emotional arousal. And what are those symptoms? So we talk about body tension, we talk about heart rate, we do lots of different exercises where we'll have people kind of clench and unclench their fists or their jawline. So things that, like, noticing differences. What does it feel like when your body's like this? What does it feel like when your body is in a different state? And noticing what those differences are. And then we take those sensations and we try to help them to connect those sensations with different emotional labels. So when might you be feeling these symptoms? Where do you feel these symptoms in your body? Is it in your neck? Is it in your jawline? Is it in your shoulders? Where do you feel them? And with what emotions do you feel them most frequently with? And then we also kind of teach, what does baseline arousal feel like when you're at rest and you're feeling the most calm and relaxed, like kind of that baseline, and kind of saying, okay, get in tune with what that feels like. And then you need to then think about what is a deviation from that baseline. So if you know that you're experiencing kind of a slight elevation in your emotional arousal or a big elevation in your emotional arousal. And then, we'd spend a lot of time teaching them that in addition to specific emotions, we teach them that their emotions, we call it, so I was talking before about thoughts, actions, physical sensations. So that the acronym is TAP, T-A, physical sensation, TAP. So I'll say tap into your emotions, use your thoughts, use your desired actions, use your physical sensations to inform you how you might feel about something, but make sure you don't confuse your thoughts, actions, and physical sensations with an emotion, because they're not one and the same. They're complementary. They coexist together, but you don't want to confuse them, but you can tap into them to figure out what you're feeling. And then we talk a lot about anger and how that's an emotion that seems to overshadow. There's always another emotion that you're feeling in addition to anger. I'm not invalidating your anger, but there's other emotions, and sometimes they're vulnerable emotions. There's, fear and worry and concern. And so we want to think about what are those other emotions. And then the last 4 sessions, we show people these videos, these first person based videos. And so one of the examples is a boss. I'll actually show you here. So first of all, before I get into that, so one of the things we use throughout the intervention is an emotional compass. And if somebody struggles with finding the specific word for their emotions, we will say, well, okay, well, tell me about this event. And do you think you felt pleasant or unpleasant? Most people can answer that. They'll say, generally, I felt bad, or generally, I felt good. If they can't, we'll then say, well, did you feel like you wanted this to happen again, or you wouldn't want it to happen again? And that's usually a good indicator if it was good or bad. Then we go through the emotional arousal. After all of that training about what is emotional arousal, we'll then go into, okay, well, was it a lot higher than baseline, or only slightly? Once you've narrowed that down, it'll bring you into a quadrant. I know there's a question. I'll give you 1 second. And then it'll put you in this quadrant. And it'll give you some options. It's not an exhaustive list, but some options of things you might be feeling based on that information. Okay, somebody has a question. No. Okay. So that's how this is our emotional compass, is how we sort of get to how we might be feeling. And then this is an example. I don't have the video up because I worry that technology is never going to work. But this example is like, you go back to work after your brain injury, and your boss is giving you a lot of work, and there's this really big deadline, and he's judging you, and he comes and yells at you in front of a bunch of your colleagues. Right. And then after that scenario, it would ask you, what would you be thinking? What would you do? So that's your actions. So your thoughts, what would your actions be? What would your physical sensations be? And then that last question is, what would you feel? What would your emotion be, and why? And if they get to that last point and they can't answer it with something specific, and it has to be a specific emotion, not a vague one, they would go through that compass. So that's essentially a description of the intervention itself and all of the different approaches that we take to reducing alexithymia and increasing people's awareness of their emotions.
Can I
So,
ask a question real quick?
Go for it.
Has there been any analysis on how effective those interventions have been?
But yeah, so these are the results, but I
Oh.
will put this caveat here, right? I said
Okay.
it was a very small study. This was a pilot study. So we first, before you go in and spend a whole lot of government money, you need to have some indicator how it's received and how. So 13 people with brain injury finished this study, average age of 46 people, most of them were male. Highly educated group of folks, mostly moderate to severe TBI. Their time post-injury on average is almost 9 years post-injury who participated in this 8-session intervention over a month. Here's what we see. So the green check marks show what we saw significant improvements in. So when you do analyses and you look at changes and you look at a whole bunch of outcomes, you have to correct for all of these analyses that you do. So so the green check marks mean they are significant even after correcting for all these, what we call multiple comparisons. The red check marks are saying we see it's significant, but once we do this correction for doing all these analyses, they no longer really fit in that window. But when you're doing a pilot study and you're trying to get a sense if something works, you don't want to dismiss something too soon. And then the X's are what didn't change. And if you could see here, this is we looked at this immediately after the intervention, and then we looked at this 2 to 3 months after the intervention ended. So we saw an initial kind of so we saw reductions in alexithymia, improvements in emotional awareness, increases in positive affect, better emotion dysregulation, or better emotion regulation, less dysregulation, less anxiety, less anger. We did not really see a movement on depression. When we looked at this further, we kind of saw that there was a split camp. Some people had less depression, some people had a little more depression, which is why I feel that, when you're going with this, you need close oversight, because you never know how somebody's going to respond to becoming aware of these emotions. So I think that this is promising, because here's the thing. What I did not mention was part of our intervention. Not once did we teach people how to change their emotion. Never. Only how to label it, how to be aware of it, how to differentiate emotions. We never taught them to change their emotions.
Question, and it involves your comment, and you can answer this later, but your comment about close contact or supervision or oversight, with someone. And who would that be? What type of professional?
Mhm.
Only
Well,
people
I
that
think
are
that's
trained in
a good question. Like for our research, it's our staff. They're trained to kind of recognize, to pay attention to things that people might be saying. With research, we pay attention to something called like adverse events. Did somebody are they becoming more emotionally distressed? Are they saying things that, and then we have resources that we could connect people to. Like we work with hospital system, with clinicians, and we get people connected with whatever help. But my thought process, when you're going through this, you really should be working with a professional, with a therapist, with somebody trained, what if it's not a psychologist or a neuropsychologist, somebody like a social worker, somebody who has training in kind of some sort of like dealing with emotional distress.
You just dropped right into my concern about who the professional would be. And I did word one of my concerns just based on the question that Randy asked about, disassociation, because in my experience, and therefore my bias with the mental health system, is really the lack of awareness of this topic of which you're speaking, and how that lack of awareness becomes the barrier to care.
Yep.
And so deferring to a professional where you would think they might have that background becomes painful and an obstacle and more trauma for the brain injured person. So I'm hoping that before we're finished at the top of the hour, you can address that.
Yeah, that's
a
that's
big one, Nancy.
it really
address it? Can I say something?
Yeah, please.
So I have this talk series and I have the podcast going where I'm talking to people about this stuff. And the last episode I put out yesterday is like this explained to the T. The person was explaining their experience, but I felt like I went through a lot of this, and I think that it's so much not on their radar that it doesn't exist. And then people, because they're professionals, they think they know, and there's other levels of judgment and frustration that can come in. And I've been thinking a lot about my experiences. And I know that I stopped talking about it or to start hiding it because it wasn't even worth it. Because when I would get into it, it would get into a really very difficult place very fast. And the person that I interviewed, it's almost like she was what she described as like a poster child for what the National Academies of Sciences report just came out, where they call it the misunderstanding. And so at least now I can talk about it because that's now published and cited, but it's a big problem. And I just think it's not on their radar. And then
it really is. It really is. And that's why I appreciate people like you guys and what you're doing with this building brain awareness, right? We need to disseminate this information. We need to get it out there. And I hear what you're saying. And I don't know the answer to the problem, other than continuing to, like I said, it's my mission to get this on the radar more, but we all have to work together to do that.
I recently read somewhere where this is not very well known among the therapeutic community, alexithymia.
It's not.
Yet it's been studied for like 4 decades.
Yes.
That doesn't make sense to me, but go ahead, Nancy. I'm sorry.
And because your goal, Dr. Neumann, is so important to get this on the radar screen, while getting on the radar screen, it would also be important to say the dangers of not knowing it.
Yep.
Because that is what we're living with.
Yep.
In a very, very harmful, dangerous sort of way.
Yep.
Definitely. I know there's a guy out in I was contacted by a guy in the Czech Republic about this, not with a brain injury, but just with alexithymia in general. And he is also so frustrated by the lack of people knowing about alexithymia. And he self-diagnosed himself as having alexithymia, created his own website. He actually created an intervention for an app for it. I'll actually show you a picture of it at the end. And he is all about increasing awareness. There is an entire, I had no idea until I met him, that there, I don't know if you guys are familiar with Reddit, if you guys know Reddit.
Yeah.
Yeah.
Newspaper
There's
of the internet.
yes, exactly. There's an entire subreddit on Alexithymia. There's an entire subreddit on it.
Can you
There's also,
provide us links or whatever?
I could send
Or
it
in
to
the
you
future,
afterwards.
yeah.
I don't have it on me right now, but I can send it to you. There's also Facebook subgroups on Alexithymia. So, but now these, again, they're not specific to TBI, but there is a world of people who have alexithymia that are thinking, this is really important. So anyway, I'm looking at the time. I see it's 3:45 and I only have a couple more slides left to go. And then I'll give you some more time to ask a few questions before I have to hop off. And I said 3:45 because I'm East Coast. So I guess 12:45 your time. So bottom line is we also had some really good positive feedback on the intervention. So we had 100% felt that the lessons were relevant to their needs, that 85% felt that they helped them deal more effectively with their emotions, and 85% that their quality of life improved as a result of the information learned. So I thought this was really meaningful and promising. I think, clear take-home points. You guys already know this is a common issue. It's related to emotion dysregulation and lots of other things. But I do think that it is promising to be treated and that emotion regulation can follow. I do feel that one day what I would love to see is this treatment used as a precursor to psychotherapy or as an adjunct or as a complement to psychotherapy. I don't think this treatment on its own is going to be the end all be all, but I think that it's an important precursor. And so one last thing two last things I want to share with you. One is we are currently conducting a study called Building Emotional Self-Awareness Teletherapy Trial. We just launched it. It is a study that is funded by the Department of Defense. This is for people with mild TBI, concussions, anybody who is 6 months or more after a mild TBI. We are doing this virtual teletherapy study on the intervention that I just described. This QR code there is where you could go. If you go to this QR code, you can put in your name and contact information, and a study staff member will contact you in a couple weeks about the study to do a phone screening. But again, you have to be 6 months post a mild traumatic brain injury. So just keep that idea out there. If you fit that criteria and you might have interest in it. The other resource I have is brainline.org. This is where I think Dr. Avasar found me. And so some of these links might be of interest to you, but that whole entire website, brainline.org, is just phenomenal. And so the top app, My Emotional Compass app, that is the app that I was telling you about before. It is $3.99. I don't get any money from it, but my research department does, the School of Medicine does. I don't personally get any money from it. We've seen no money from it yet, but that's okay. If it was up to me, it'd be free. But anyway, there is this other one. This is the guy from the Czech Republic. He had created this. And if you actually go to his website, he actually has a whole, I don't know if blog is the right word. Called it something, I forgot what it is, but actually it was very good. It was very informative, I thought. And I checked out his app. I like it. There's pros and cons, I think, to both of ours, but I think it's not a bad resource. I think with that, I just wanted to say thank you and show kind of recognition to some of our team that's helped out with this research, and ask you if you have any questions for me in the last 10 minutes. I know we had a lot of discussion going on, and I will say that I have not been able to monitor questions. So if people send stuff to me directly, I have not read them. So anyway, well, thank you for your time and attention, and hopefully together we can increase awareness.
This was really good.
Thank you.
This was really good.
Thank you, Randy.
And you're the first
that.
person in 25 years that even touched upon this subject, from my experience. Never came up once with anybody in the healthcare arena.
Thank you.
Thank you.
Keep going,
You
Don.
too.
Keep going.
I know I spent a fair amount of time at RHI, and I know you guys, this has been a constant thing you talked about with me. So I definitely appreciate all you've done. So.
Thank you, Bill. Yeah, it's really great to have you join us. Just watching your progress over the years, and it's been really great to work with you and learn from you, and vice versa, help each
Can
other.
I ask a question, Don?
Yeah,
If
please.
you've had damage to the limbic system, how does that how do you fit that in? I'm not sure I'm not even sure if that's the right way of putting it.
What do you, well, I mean,
because you're talking about the amygdala, the hippocampus, much of which is, drivers of your emotional response.
Right.
And,
So
go ahead. Say what you're gonna.
What I was gonna say is I think that some of that might be where the difficulty is, because so when some people say I have no emotions anymore, how do I know that there really is no emotional response versus there being something there that's beyond the detection? Like, I don't know if like the limbic system is injured. Like, I guess I don't pay too much attention, I will say, because in TBI, there's so much diffuse injury,
right?
And nothing's typically, unless it may be a gunshot wound, there's nothing obliterated. There's still stuff that's left. There's neuroplasticity. So like, I feel like things are still there. They're just not functioning quite as well. And so it's just kind of like that retraining and building that muscle growth. But like, again, it might be harder, take more, I think, to trigger an emotional response. Like I know a lot of people, if you're thinking about limbic damage, is somebody going to have a harder time experiencing fear or concern or worry, like some of these emotions that it's more consistently a part of. But I think it's complicated to say, and I don't know the exact answer to that question.
Okay.
I can say, and I've been talking to Randy, and then I have a few questions, just I'll shoot them off real fast. But I think that one thing that I experienced with, especially with cognition and very specific aspects of cognition, is they were obliterated. There were capacities that I knew before that were gone. And I called them my mental holes, and other people call them blind spots and then black holes. It's the same discussion. So it's a part of you that almost doesn't exist anymore. And I don't believe I had injury like that to my emotional regulatory stuff or emotional feeling stuff. I think I had a different issue, which was not being able to feel it because there were so many issues on the table. So I think it could be possible that someone has that limbic injury, and then it would just make it that much harder to experience the feeling.
Yeah.
The question I had, and maybe either we can go back to that compass that you had, or we could just describe the compass.
Sure.
What do you do if a feeling is too overwhelming to even deal with? Because that's when I started tapping into my brain injury stuff, and that took about 17 years. It was so overwhelming. You can't, it's not like something that you can just have that, I'm feeling it and developing an awareness of it. It's just, it's intolerable, especially in the beginning. So do you guys have any ways that you were able to deal with that, or?
I think that's a really good question. And I think that it's probably a really difficult thing to navigate. But when you have a really intense feeling, are you able to describe what that feeling is?
Over the year that I went through it, I realized it was pain, and just like an inability to feel pain in my own suffering. And like
physical
what do you
pain
mean
or
by
emotional?
pain? That's thank
physical
you.
pain or emotional pain or both.
Emotional pain, connecting with rage, connecting with the whole, because the whole thing happens, and once you're aware of it, it's just this it was an overwhelming feeling, and it took some years to gain the connection with my feelings, and then to be able to tolerate that overwhelming feeling. And then it just I guess the pain of the whole injury. And I guess the first question is, how do you deal with that if they have that overwhelming thing? And the next question is, do you think there can be injury to specific of these emotions more than others? Because I know that across my recovery, and let's say the 10 years after my brain injury, I was very good at dealing with frustration. but I couldn't even tap into that emotional pain until, it took like 20 years to get there. So can there be injury to different emotions?
Yeah, so
Interesting.
the going back to your question about being overwhelmed, so I think it's an interesting question. We frequently have people go through our training, when they're asked to talk about their emotions, people will constantly describe, I'm stressed or I'm overwhelmed, and that's their way of describing an emotion. And I think when you are feeling, you have this intense feeling, it's harder to think, right, with that prefrontal cortex, right? It's harder to
Absolutely.
think
Yeah.
straight, right?
Right.
But, I think that's kind of one of those things where it's important to try to, I think one of our patients that we had that came through the program, that she used to talk about feeling flooded with these intense emotions. What she liked about this program, and I see Dr. Langston is on this call, and he was actually mentioned on there as a person I recognize because he did this first pilot study. He was the clinician and really talented and worked with this individual. But anyway, so hey, it's really great to have you. You already know all this stuff. So anyway, thank you for joining. But anyway.
Yeah, well, I mean, to kind of this point, I think one thing that this program does well, and I'm not going to turn my camera on because I'm on dad duty with the 4-month-old, but is that to that question of what do you do when it's so overwhelming, is that going through these questions systematically, I think slows the whole process down. And the other thing that I think it does well is not only gives options which is like an awareness building strategy, but it allows for multiple emotions of the same event at some point, and saying, look, there can be more than one, and this was really overwhelming to me. I have multiple. Okay, let's break this down a little bit more. And then I think that was a good strategy also, kind of to Dan, your point or your question of, what if I just can't get there? Well, okay, let's slow it down, and it could be multiple. And I think it did a good job of that.
Yeah, I like that. I guess
Thank you.
in theory, because with all of the stuff that I know very well from my cognitive rebuilding, it was really this crazy chipping away, and it's almost like you don't impact the big thing until you start doing all these little tiny baby steps for a long, long time. And so that they're very different capacities in us, but that what you said kind of makes sense. Because you got to start somewhere and you got to work on it in some way. So yeah.
Yeah, and I think that was part of like that lesson 5 through 8. It was sort of this practice, like let's practice in these scenarios that are supposed to be highly emotional, but yet they're kind of structured and controlled. And now let's practice you kind of figuring out, oh man, this gets me so, angry or whatever. It's like, okay, well, let's think this through. Let's think through, what are you really feeling, and process this. And so you're practicing in the moment of an emotional scenario, stopping and thinking, what am I feeling and stuff, and what's going on? What am I thinking? What am I, my physical sensations, and slowing that process down. So, and I think the other thing that Dr. Langston did really nicely with this, with regards to like kind of these multiple emotions. So we push people to acknowledge these multiple emotions. So I think when you were saying before about being stuck, or just like, does it impact certain emotions more than others? I think at the beginning of this presentation, I showed, it's like people always seem to always still acknowledge that anger is like, oh, I'm angry, or I'm nothing, or whatever. So it's like people would get stuck in quadrants, and there was this kind of, we would have this goal to push people to say, well, you could be both pleasant and unpleasant at the same time, or you could have an emotion that's highly aroused and lowly aroused at the same time. Like and we would sort of challenge to think through, like, what other emotions might you be feeling here, and delving deeper into that. So I just think that some emotions are kind of overshadowed by more intense feelings, and you just have to sort of reconnect and rethink and pay attention to what are those physical cues that are associated with these kind of other emotions that are kind of less obvious.
Thank
Were
you.
many
And
people
I'm
on the,
wondering,
go ahead, Nancy, I'm sorry.
I'm wondering if I could just chime in and ask you to state the obvious once more as we're beginning to wrap up.
And you have
because-
to go. I know that Dr. Newman has to go, so you can make
Yes.
a final statement. And
And
then we'll
And
continue.
is this, I'm sorry, is this condition less feelings or less understanding what these feelings are that can be monumentally intense?
So they're not less feelings, they're just less understanding. And I'm so glad you said that, because I make that in almost every presentation. I don't know I don't know why I didn't this time. This alexithymia does not mean having no emotions. It means having emotions with no labels or no awareness. So it absolutely is there and needed. So thank you for asking that question. Thank you for having me. This was really wonderful. I appreciate all you guys. I look forward, Dr. Avansar, to being back in April to talk about the negative attribution stuff. Feel free to let me know if you guys have any questions.
Yeah, can you do part 2 of all this? Some point down the road.
Yeah, actually, I would not mind. We're learning stuff all the time, so we can talk about that another time. I appreciate it. I do have to run, but thank you.
Thank you.
Okay.
Yeah, thank you for your time.
This was